Welcome everyone to a discussion sponsored by the Global Health Justice and Governance Program in the Heilbrunn Department of Population and Family Health. My name is Terry McGovern. I'm the chair of this great department and the director of Global Health Justice and Governance. For those of you who don't know the department, we focus on the most complex health issues facing the most vulnerable people in the world: the health of migrants, environmental injustice, gender justice, sexual and reproductive health. Our faculty also work in clinics here in Washington Heights and have been on the front lines of responding to COVID. A lot of our research is also on the impacts of COVID. We do understand health as a human right and work side by side with populations for whom this right is consistently violated. We use science and evidence to disassemble the structural barriers, including policies, law, and funding schemes that make good health an impossibility for so many. But let me turn to the global governance issue at hand: vaccines. We have an amazing panel of experts who will help us see our way out of this mess. But to get us started, I want to give a bit of context. Our school is in Washington Heights, New York City, which is experiencing a surge in cases. Among the pandemic's many profound impacts are massive job losses, economic hardship, a disproportionate impact on women, school closures disrupting education for 1.5 billion students, spikes in reported cases of domestic violence in many locations, reduced access to basic health services, including routine immunizations, sexual and reproductive health care, abortion. We all know the virus worsens existing inequalities, disproportionately impacting seniors, frontline healthcare, and other essential workers, communities of color, people living in poverty, and people at more risk due to pre-existing conditions. As I was preparing these remarks, I kept feeling like I was on the verge of tears, whether that's because we're about to get a vaccine, or it's because I saw so many people die in 1995, right before treatment was available for HIV. I saw so many people around the world die because they didn't have access to treatment that people in the US had. So these thoughts are very much with me when I think about this vaccine. So who gets the vaccine and who doesn't? How will we convince people to take the vaccine? Who pays for a vaccine and its delivery? In May 2020, 140 world leaders and experts advocated that all COVID-19 diagnostics, treatments, and vaccines be treated as public goods. They called for a people's vaccine, free of charge for those being vaccinated. And they said these are global public goods in the interest of humanities. We cannot afford monopolies, crude competition, and nearsighted nationalism to stand in the way. So what's happening? Globally, Nina will discuss this in much greater depth, but at the global level, there have been two approaches which will be discussed. The first is the WHO COVID-19 Technology Access Pool, CTAP, championed by the Costa Rican government, promoting technology transfer and global pooling and sharing of intellectual property. It's kind of aligned with the aims of the People Vaccine. The second approach is a vaccine procurement effort led by GAVI, the Vaccine Alliance, a public-private partnership. It does not require technology transfers or the open sharing of IP for companies to participate. This will be discussed. The WHO proposes each country be allocated a batch of vaccines to cover 3% of its population, at a minimum immunization of frontline health workers. Then additional batches would be allocated until every country had received sufficient doses to cover 20%. But we know that governments are handling vaccine development totally differently. Some governments, especially high-income countries, are directly negotiating and funding their own bilateral agreements with pharmaceutical companies, universities, research institutes. They're also reserving future doses of vaccines. Some governments are pledging funds to COVAX. Some high-income countries are doing both, signing bilateral agreements and participating in COVAX. But high-income countries will be likely to improve their situation and economies the quickest, as will middle-income countries that have significant vaccine manufacturing capabilities. Will this exacerbate global inequality between countries? Some of the countries that have the highest per capita death rates, Iran, Peru, Argentina, may have far less vaccine availability. The within country is also a big challenge, supply chain issues, local capacity, leadership. The panel will discuss all of this. Our research on COVID has shown consistently that vulnerable or criminalized folks, migrants, LGBTQ people, sex workers, adolescents seem to fare the worst in accessing anything. How will vaccine access be guaranteed for these populations? Are there human rights obligations at play here? The International Covenant on Economic, Social, and Cultural Rights, 171 state parties, the US signed but didn't ratify, recognizes international cooperation and that states must take joint and separate action to achieve the full realization of the right to health. States are required to direct the efforts of business entities towards the fulfillment of the highest attainable standard of physical and mental health. This would mean including specific extraterritorial obligations. States should be controlling the activities of corporations under their jurisdiction so they don't interfere with the right to health globally. So obviously a component of the right to health is taking steps for prevention, treatment, and control of an epidemic to the maximum available resources. Governments directing money into vaccine development and manufacture should be imposing conditions on that funding to ensure the right to health is fulfilled. Some recipients of government funding, universities, pharmaceuticals, have said they're going to adopt not-for-profit funding or minimal profit, but information on this is scant or vague. The current environment has a near total lack of transparency. We do not know the terms and conditions of government funding, how much has been pre-booked and for whom, what manufacturing facilities will be used. In September 2020, Oxfam International analyzed available information on deals made for 5 of the 9 vaccine candidates. They estimated that 51% of doses were reserved for high-income countries, even though they represent only 13% of the world's population. So the panel will discuss the parts of the world that do not have significant manufacturing capacity. Will be dependent on imports? The panel will discuss in October 2020, India and South Africa proposed that some provisions on the Agreement on Trade-Related Aspects of Intellectual Property Rights be waived to allow countries globally to collaborate without the morass of laws and restrictions governing intellectual property. If adopted, this could enable the sharing of technology. There is currently little or no public information about whether governments funding vaccines have included march-in rights, that is the right to override any exclusive licensing arrangements. The Bayh-Dole Act establishes this mechanism for the US. Just to summarize, the World Bank projected the pandemic could push between 70 and 100 million people into extreme poverty. So there's a lot at stake here. And I guess I want to question the deference to the regime of confidentiality, corporate secrecy, proprietary exclusive rights in this context. And this is why we're having this conversation today. Including what about discrimination, corruption, et cetera. Just to close on New York City for a minute. We're about to get the Pfizer vaccine on December 15th at Columbia. You know that we've had the highest total deaths in the Bronx, Queens, Brooklyn. We know that the Trump administration invested in Operation Warp Speed. The US has subsidized vaccines. There's some statements that there's a rule that any FDA-approved COVID-19 vaccine would be covered at no cost to seniors or low-income people coming out of the Centers for Medicare and Medicaid Services. So there's some conversation about pricing issues. But we all know we have a big problem here in the US, even if a vaccine is available. The history of racism and experimentation on communities of color, the recent history of lies and politicization of science, the ongoing systemic abuse of the very same communities most affected means even with access to the vaccine, we have a lot of work to do in New York City. With that, let me introduce our fabulous panelists. One of the great pleasures of being back at Columbia is that I get to partner with Chelsea Clinton, our moderator, who didn't want me to say much. She's been a long-term advocate for vaccines. She's an adjunct in the department. She partners with our global health justice and governance all the time and possesses a robust heart and mind. So I'm delighted that Chelsea is with us today. Then we have Dr. Ian Barton, is the CEO of the Clinton Health Access Initiative and is an expert in developing and implementing best practices in global health. He's a medical doctor with 10 years clinical practice, 20 years in healthcare business management, and he specializes in pharmaceutical supply and market shaping, key supply chain and distribution initiatives. Next, we have Dr. Precious Lunga, who is the CEO and co-founder of the Baobab Circle, a health technology company that uses artificial intelligence, behavioral science, and telemedicine solutions to improve quality of and access to healthcare across Africa. She's a trained neuroscientist and epidemiologist with vast experience. Next, we have Nina Schwab, who is an adjunct in our Department of Population and Family Health and the CEO of Spark Street Advisors, a public health advisory service that provides policy and strategy guidance to governments. She's held numerous positions, including Managing Director of Policy and Performance at Gavi, the Vaccine Alliance. We're very lucky to have her today. And last, of course, but not least, is Dr. Prashant Yadav. Dr. Yadav is a globally recognized scholar in the area of healthcare supply chains and currently serves as Senior Fellow at the Center for Global Development, an Affiliate Professor of Technology and Operations at INSED, and a lecturer at Harvard Medical School. So thank you all so much for participating, and over to you, Chelsea.
Oh, Terry, thank you for that kind of fulsome introduction and for welcoming us so generously into this important conversation. We certainly hope that this will be a conversation. So while I will ask our panelists a series of questions, I hope that they will also kind of freely engage with one another, and we hope to hear from all of you who are joining us today. So please submit questions through the Q&A function, which we will be monitoring regularly. We want to ensure that your questions also will be heard and that the panelists will have the chance to address them. As Terry laid out, there is kind of so much that needs to be discussed kind of through a rights-based lens. And so I will try to kind of maintain kind of discipline about focused on kind of the rights-based dimension and dynamic of this conversation, because clearly there's so much that needs to be wrestled with there, and I don't want to lose our focus. I also really appreciate that kind of Terry laid out the challenges that we confront here in New York City, as well as kind of in the United States and certainly around the world. And I hope that we'll have the chance to kind of engage with kind of those different levels of geography throughout our time together. But Nina, I want to start with you and just to kind of have you perhaps discuss kind of what has happened at WHO and at Gavi kind of through CTAP and COVAX, in case people may not be aware of kind of what these entities are, kind of how from a global governance perspective, there has been an effort to ensure there is kind of some kind of rights-based kind of scaffolding built into these programs, but how realistic do you think kind of the rights-based kind of girding will be kind of once we really do have sufficient quantities of vaccines to be distributing around the world, and then other also kind of supportive kind of testing and kind of therapeutics So just really would appreciate kind of you sharing thoughts and reflections, because while we may be familiar kind of with what these acronyms mean and kind of have our opinions of kind of what they will mean in practice, I imagine a lot of people joining us today may not.
Great. Thank you so much, Chelsea, and great to be with these awesome panelists. And thanks, Terry, as well for inviting me. So it's true that there are a ton of acronyms out there, and even the people that are supposed to, sitting within the acronyms sort of get them wrong. So let me just start with a couple of things. So there's a couple of things at WHO. There's something called the Act A, which is the Access to COVID-19 Tools Accelerator, and it has three pillars. One focuses on drugs, the other focuses on diagnostics, and the other focuses on vaccines. So you'll hear talk about the Act A or the Act A Accelerator. There's also something called the COVAX facility and the COVAX AMC. And these are two slightly different things. And the COVAX AMC is part of the COVAX facility. So the facility is hosted at Gavi, the Vaccine Alliance, which Terry mentioned. Gavi was founded in 2000, essentially as a pooled procurement agent for vaccines. And the idea was to bring together the buying power of the poorest countries in the world to be able to order enough volume to have good negotiations with the pharmaceutical industries. And now it started with a couple of vaccines, and now it provides many different vaccines, antigens to the world's poorest countries. It's really focused on the world's poorest countries, and that's a little bit of a difference with the COVAX facility. But they're used to doing it. They have a couple of procurement, what they call partners. UNICEF is the big procurement partner. Countries apply for vaccines. It goes through a rigorous process. They have to have their systems in place, and then essentially UNICEF makes sure that those countries and countries, even for regular vaccines, which are measles, human papillomavirus, pneumococcal vaccines, countries have what they call a small copay. And it's pretty small, actually. It's like 20, 30 cents per dose, depending on the vaccine. And then when a country reaches some sort of economic threshold, the payment for that vaccine goes up. And the reason why I mention that is because in contrast to that, the kind of COVID copay is pretty significant, sort of like a factor of 10. But it is a regular feature of Gavi that countries don't just get it for free. They have to have some skin in the game. And Prashant and I have done a lot of, I've been very influenced. I'm so glad he's on this panel about thinking about how you value vaccines. Prashant said, if you have like caviar in your fridge, you're going to make sure that your fridge is working, whereas if you maybe just have some old eggs, you have a different level of investment about how your fridge is working. But the value of Gavi vaccines, ranges to about $3.50 for what people are normally handling for the value of those products. That's kind of the high end. So if I just go back to now talking about the facility and the AMC. So the facility was set up, as both Chelsea, you mentioned, and Terry mentioned, to bring countries together to pool procurement and think about demand forecasting as one whole. And again, this is something actually where I first met Prashant, was thinking about demand forecasting before, and Ian and Chai have done a tremendous amount of work on this, is to say, if everybody thinks about their forecasting separately, the numbers don't add up in the end. So one of the benefits of Gavi, in particular around vaccines, and the Global Fund does this with HIV, they're not unique in this, is getting everybody's forecasts together so that there can be a fair allocation of supply in the end. So the facility has two parts to it, and one is I'm a non-ODA eligible country, and I just want to buy stuff, and I want to be fair and make sure I'm part of this equal allocation system. So I think there are 192 countries now participating that have said to some extent they want to be involved in this procurement, and there's different ways they can buy in. They can pay a lower payment and then be more committed when the vaccines are available, or they can give a higher upfront payment and then have more choice when the vaccines are available. Those are for rich countries, the US, Canada, anybody can do that. And then there are countries that are eligible for a big subsidy from donors, and that's where the COVID AMC comes into place. And what that means is countries still have a copay, and it's not small compared to kind of normal Gavi copays, so it's somewhere between $1.20 and $2 per dose, but then the rest is covered by donor countries. Now, when I say the rest, What I mean is the cost of the vaccines. And this is also kind of an important point. Bruce Gellin gave a talk I was part of a couple of weeks ago, and he really emphasized the difference between vaccines and vaccination. So vaccine is the thing. And then vaccination is all the cost that it takes to deliver that thing to people. So this is really only primarily about the cost of the vaccine. Gavi has some other money. They have about $150 million to help countries do the cold chain. And again, my colleagues on the panel are going to talk about how complex that is. But the primary money that they're raising now is really for the cost of the vaccine. And then there are so-called delivery costs. And for poor countries, UNICEF's estimating, that again, it's going to be somewhere up to maybe $2 per dose, delivery dose that countries are going to have to come up with. And there's an effort by the World Bank to help finance that. $12 million has been committed by the World Bank to help countries both pay for their copay on the vaccine, and they're calling it a co-commitment. They don't call it copay, which is the normal Gavi language. They have a special word, co-commitment or something, or they have a different new word, or to help countries as well pay for some of those delivery costs. Now that 12 billion it's World Bank money, so it's probably going to be a loan. It's not necessarily free money, but the terms depend on what the income is of your country. Just a few more things on COVAX. Their aspiration is to have 10 or more candidates in their portfolio. They're trying to get a commitment by manufacturers up to 4 billion doses. That sounds like a lot, but there's always attrition in R&D. And one of the ideas of an AMC, or the advanced market commitment, is that before the vaccine comes to market, you have a firm commitment with manufacturers, and you promise them some money up front so that they know that when they make it, there'll be people there at the end of the day to buy it. And they've raised about, I think I just looked it up, and it says they've raised $2 billion, but they've got a significant way to go. They're doing a second round of funding now for another 5. So I will just say a few things about the concerns. I can talk about all the country readiness. UNICEF and WHO are basically involved with some other partners in getting countries ready. There's lots of tools and assessment tools, and countries have to fill out an application to apply to Gavi. And this is all work in process. And there's a very long list of different types of assessment tools with lots of different acronyms, VRAF, VRACT. They're actually a bunch of different tools that are required by different agencies. And but it's a super impressive global effort to get everybody together. Again, sorry, just a couple of the concerns around it that I think people are thinking about who are thinking about the access and rights issue. One is the pricing and copay. Sort of, where does this money really come from? Is it a zero-sum game? Is it a shell game? Is it going to come out of other primary healthcare services, out of routine immunization? It's not a small amount of money compared to what Gavi normally requires for countries for vaccination. This is definitely of the sort of caviar version in the fridge. They have to raise money for the AMC. That's the subsidized portion for the poorer countries. And unless they raise that money, they won't be able to provide the poor countries with the needed doses. There's a real concern that the vaccine in general also will detract from not only routine immunization, but also from regular maternal child health services. Campaigns are really big deals and normally detract. We have a lot of history in vaccine campaigns of perverse incentives and everybody just sort of going towards a campaign and forgetting about everything else. Civil society engagement, pricing transparency, and then also kind of what's the point of this? And is it about individual immunity, or is it about herd immunity and clarifying those issues for people, especially if countries are starting with 3% and then sort of best aspire to 20%. So that was probably a lot. I talked super fast New Yorker style, and thanks for that, and happy to answer any questions.
No, thank you, Nina. As a New Yorker, it felt right on cadence for me. Totally normal. You did give us so much to think about and so much I want to return to, but since you did mention Prashant a few times, I'd like to next go to you, Prashant, to just talk about kind of the challenges of going from, as Nina said, vaccines to vaccinations, and just from your perspective, kind of thinking about supply chains and trying to think about equity and kind of equitable distribution, and then kind of what will be required of global supply chains and delivery. Kind of what do you think we should be thinking about kind of from a rights-based perspective? And do you have any hope that kind of there are kind of rights-based kind of thinking and tenets informing kind of how the acronyms that Nina talked about, as well as kind of governments themselves are thinking about moving from kind of the procurement of the vaccine to then actual kind of vaccinations of people.
Yeah, thanks, Chelsea. I've enjoyed learning from Nina quite a lot in the last couple of decades. And what we know about the supply chain for vaccines is that if we want equitable and a global rights-based rollout, then we need more manufacturing capacity, right? So it all starts at the top, which is how much manufacturing capacity do you have? And then we get into tactical issues about how much can we distribute, what kind of challenges. So if we think about manufacturing capacity, I think we hear a lot of discussion that focuses on IP, intellectual property and other related issues. But a key thing about manufacturing capacity is that we need to think about a model of scaling out manufacturing capacity. And what I mean by that is a vaccine sponsor, a company which has developed has a vaccine candidate which is likely to be approved or authorized, they need to think about who else can manufacture that product globally. And many of the companies are willing to engage in a scale-out model. Some have already done that with many large developing country manufacturers, which Gavi and other partners of the alliance have helped in the past with other vaccines. But in selecting the plants, we also need to think about flexibility this time, because we need to think about selecting manufacturing plants and contract manufacturers who can manufacture more than one vaccine candidate, so that if one succeeds and the other doesn't, or if one succeeds with higher efficacy and the other is lower, and we want to think about switching from one to the other, we have the ability to quickly reconfigure capacity. And that flexibility and reconfiguration capacity is something we need not just for COVID-19, but for preparedness against any future pathogen and ensuring an equitable distribution of vaccines for a future pathogen. So that investment is something we don't see coming out in this global infrastructure and the various things that Nina described. There are some investments coming out of CEPI and COVAX, but again, we need more in flexible capacity, quickly reconfigurable capacity. The second is when a company which is for the first time developing a vaccine, and let's say they are successful, they are not like the bigger life sciences companies who have in the past worked and transferred their technology to a developing country manufacturer. These are companies who in some cases are smaller biotechs, mid-sized companies who've never themselves commercialize a product. So while they are in principle at times willing to engage in a partnership agreement to transfer their technology to a developing country manufacturer, there isn't a clear mechanism to support them. The onus should not be on the company. If the company is willing, we should then have a structure which can say, we'll connect you with the developing country manufacturer, we'll help you with all that is needed. It's not easy to do tech transfer in the times of a global pandemic. So we should think about where this gets situated in the various things that Nina described, the Act A, COVAX, many other things. Then I think I want to remind us that vaccine to vaccination depends upon auxiliary material that needs to be present alongside with the vaccine. And auxiliary material implying, vials, syringes, diluents, lots of things that have to be present together with the vaccine vial. And we sometimes think of them as an afterthought, right? We say, sure, let's invest our resources in manufacturing vaccines. But it's important to keep in mind that vaccine is something that we can airship, right? We can put vaccines, and most of what you will see in the next few weeks will be air shipment of vaccines. But syringes or other things that we need are what are things we can ship now. They are highly uneconomical to ship them through air. So let's pre-position them, think about how do we get them in the places where they'll be needed, where manufacturing occurs for them, and so on. And then I think to deploy the vaccines, we need well-functioning in-country supply chains. Many countries are starting to make their plans right? They are still unclear on whether they should plan for ultra cold chain, which is what you need if you need a vaccine that requires minus 80 degrees centigrade, or a cold chain, or something in between if you require minus 20. And the reason there is uncertainty about what is coming their way, one of it is, well, we don't have vaccines approved or authorized yet. But the second element of uncertainty is that while they know that they will get 3% initially and 20% eventually from the COVAX facility, if they are an AMC country, which is the country that's getting subsidized or almost for free vaccines from COVAX, they don't know how will that allocation happen. Will they get the Pfizer vaccine? Will they get the AstraZeneca vaccine? Will they get a future Novavax vaccine? What will come their way? And will it be they'll get only one? Or will they get a stack of vaccines from COVAX? Will they get, like, let's give you, 5 different types. And supply chains in infrastructure weak settings don't work well when you add additional elements of complexity in the form that, oh, you don't have to move just one vaccine, you have to move 4 of them through this very weak and less developed infrastructure. And on top of that, we can't tell you what will be the characteristics of the product that you have to move. Last thing about supply chains is that supply chains serve beneficiaries using slightly different channels, right? People go to get vaccinated in the adults primarily, in the private sector, in the public sector clinics. And this varies from country to country. This varies depending upon whether a country has an adult vaccination program at all, or it's largely focused on under 5 vaccination. And the supply chains that serve each of them are different. So how much will be allocated to each is going to determine how equitable is the distribution. We can create all the tools and allocation frameworks we want at the national level, at the global level, but in the end, it is the supply chain that has to deliver to the intended target beneficiaries, and it has to figure out what is the route that will get me there. And we are not ready for it because we design supply chains with the idea that how can I maximize the number of people I can vaccinate? But we need to design them with the lens that, is this supply chain design also going to cater to the groups which are likely to get neglected or marginalized? One example would be that if in a country, not just by socioeconomic quintile, but people who have been infected and have recovered and therefore feel that they don't want to be the early adopters of the vaccine or vaccines, that pool then in which they come becomes smaller. So someone who's designing a supply chain with the metric that I want to maximize the number of people I can with my limited resources says, why go after this sub-segment of the population, because very few of them are anyways likely to get vaccinated. So that creates a self-fulfilling type of cycle where the few in that group who did want to get vaccinated are less likely to receive the vaccine because the supply chain isn't wanting to serve them. So I think those are many issues, little strands of things which appear scattered, but require us to use the lenses of equity in designing our supply chain, in designing our sourcing decisions, and in thinking about flexible manufacturing capacity.
Thank you, Prashant. Precious, I want to kind of turn to you next, because in our call a few days ago, you spoke about kind of what you thought the role of the Africa CDC could be, and also kind of what you saw as some kind of countries across the African continent being, I think, more well prepared to perhaps answer or navigate the questions that Prashant and Nina have raised, and those that have been less well prepared. And so I wonder if, now that, since we've talked about kind of the global level and the national level, could you talk about the regional level and kind of how you think the African CDC could help provide stewardship here, and also kind of what you see as perhaps some points of real hope for countries that you think are doing at least a better job of kind of answering these supply chain and kind of distribution questions with the real kind of rights-based view.
Okay, thanks, Chelsea. Well, I think Prashant and Nina pretty much covered a lot of what I was going to say. What I really want to highlight first off, actually, is that for me, what's been a big beacon of hope over the COVID period is how actually the African countries have got together to actually tackle COVID itself by having calls, under the stewardship of the policies made by Africa CDC, has meant that they've been tackling these issues around, okay, vaccines, what do we need, how do we deploy them together? So on the one hand, we've seen with the richer countries how there has been a sort of me first attitude. What gives me hope, first off, is that in Africa, it's been let's work together as a collective. Now, more specifically around the vaccines, Africa CDC does have has a strategy around that, and one of the key areas really is around even the research that is being conducted from an equity-based approach. We know that research has been done in probably areas of high transmission. So you have Brazil, you have some South Africa, other places where research has been done. What we want to see is that then the fruits of that research, because when it came to preparing, getting the data we need for the COVID vaccines, the globe participated. What we want to see is that when the distribution of a vaccine that's been found to work, we want the low-income countries to also be active participants and not be some of the last countries to actually get the vaccine. I know some of the arguments have been put forward. Yes, there are challenges with supply chain. There are a lot of lessons have been learned from childhood immunizations. It's not the same as adult immunizations. It's also going to be really important that we maintain those childhood immunizations. So a rights approach is also about rights. It's about rights to health. And that also means not neglecting people suffering from other conditions. We have to remember that at the same time there's a COVID happening in terms of an outbreak. There are other countries that are having an Ebola outbreak right now, and across the continent, and other infectious diseases. So all of this has to be put into play when considering the costs. So with a $350 sort of copay, before we even put the cost of the transportation, the cost of the syringes, the cost of the storage, the health workers, the follow-ups, it all then starts to mount up. So in terms of the challenges that low-income countries have to face, then they're having to make the decision of, okay, so we fund the COVID vaccine and it's proper and right. What is the actual cost in the end? Because to me, it seems to say when we use a 350 figure, it's a bit disingenuous because we haven't added all those other amounts. And I would really, following on what Prashant said, it would be really good to really understand what those ancillary costs are, because then countries are really clear in their mind that this is what goes into the budget, rather than adding on, because obviously once you've bought your 3 million doses, however many they are, then you have to make sure you ship the syringes, etc. And so in terms of a global health perspective, what role can richer nations play in making sure that we approach this in a holistic manner, where we are building in those costs? So it's really, how much does it cost for for the vaccine to literally the shot in the arm, wherever it is, be it in a city or in a rural area? That cost needs to be accounted for, and some transparency around that would be, I think, an important first step towards a rights-based approach. Another area that I would like to add on is that we're already hearing that some countries or airlines may be saying, well, if you're not vaccinated, then you can't catch this flight, or maybe at some point we hope it won't happen, but what if there are countries that won't allow certain people to arrive if they're not vaccinated? So what would then happen is then the world becomes split, where the richer countries that have access to vaccinations and systems that can cater for it can have, can move around the world, can have more open economic activity, whereas the lower income countries that may be even just starting off with a 3% and really hope eventually to get to a 20% become impeded, which would mean then the disparity in terms of economic output then will grow over time because of COVID and not lessen. So I'm asking the question, because I don't have the answer, is how do we put that all in together? Because we are talking about global health. It's also about the economic health, because if we don't get this right, then people will be left poorer and carrying the larger burden. And we saw that with HIV, and we don't want to see that with COVID.
Yeah, thank you, Precious. I completely agree. Ian, I appreciate kind of hearing your thoughts on two fronts. Kind of one, given as Nina and Prashant both said, kind of all the work that Chai has done on supply chains, and especially kind of with WHO kind of over this year, kind of with an eye toward COVID. Kind of any thoughts that you would share, kind of as how rights-based kind of principles have been embedded in that work and in our work. And then just secondly, this real concern around global health being a zero-sum game that Prashant and Precious both kind of touched on, that, if we're doing kind of COVID vaccinations, we're then not doing pneumococcal vaccinations, or if we're kind of, recruiting healthcare workers to do COVID vaccinations, the healthcare workers are not kind of, attending births to ensure that kind of newborns and mothers are safe and thriving. And I know this is something that you've, thought about really throughout your career, is how do you ensure that kind of health investments that may be ostensibly purposed toward one area can really help strengthen the system and not kind of draw from it or detract from it in real ways. So really, Ian, just appreciate hearing your thoughts on those two fronts.
Well, thanks, Chelsea, and thank you also to Terry for allowing me to join. It's maybe worth putting a bit of context around where Chai fits in and what we do. So the Clinton Health Access Initiative has spent nearly 20 years serving partner governments in low and middle income countries in their work to serve the healthcare needs of their populations. And we do that by working with donors and multilaterals, but we work at the service of those national governments. And so our involvement is around input, it's around innovation, it's around definition, convening, catalyzing. We're not actually the decision maker. We often the executor of the decisions that get made, and obviously getting the work done and supporting and assisting getting the work done. But that's the role that's where we fit in. Getting into the detail of the global rights-based COVID vaccine rollout, it's the rights of people are vitally important, but also the rights of low-income countries is a really important topic, and I think that's where we've been able to provide the most significant support. And I think there's really sort of three loose groups that it falls into. There's what are the impacts around normative values and ethics and approaches, and then what is the logistical aspects around the context and the logistics and the costs, as Precious said, and then what broader potential can we hope for and indeed push for or promote, because it's not just about what is the zero-sum aspect and what's got to give in order to get this in. It's also about saying, well, if we're going to incur lots of debt, we're going to incur lots of spend, how can we ensure we get the maximum return on that investment? And so low-income countries are really facing complex decision-making now around the vaccines. They've got lots of different competing priorities, and health priorities and economic priorities. Many have often got a relatively low COVID-19 burden and lots of burden around lots of other conditions. And also large uncertainties, as Prashant mentioned, about how much of which vaccine they'll get when. And not only the cost of getting it procured, but then the cost of actually delivering it into the patient arm, that getting the vaccine into vaccination. And that's where we need the concerted approach across society in hopefully responding to this as a public health crisis and using this experience for more than just giving jabs. How do we get the maximum return for effort and spend? This process could do so much more for the access potential of people in our countries. And it could be an opportunity to strengthen the actual public health systems. There's investment in capacity and human resources and systems that's going to be necessary to do that. And we need to ensure that we're applying our minds to make sure that we're building that as something that can then be applied to other things other than just this pandemic. It could even be used to enhance the status and the perceptions of community health workers and to leverage the breadth of contact for issues such as health literacy, for digital health record expansion, something else that Precious is working on, for program recruitment, and even for screening for other conditions. So yes, there's been lots of impact on existing programs, but we must exercise our minds around what the potential could be for this process to either to catch up or to, in fact, even move past where we were before. In the rollout planning, there's all the considerations that are being made and the thinking that's being applied by COVAX around the prioritization of health professionals, caregivers, and other frontline workers and comorbidities that are vital, but we also must contemplate the issues of vulnerability of migrants, of prisoners, of persons in detention facilities, of displaced persons, and of course, gender balance in rollout. We need to make sure that we're aware and discouraging and optimizing product movement rather than seeing hoarding of supplies. And then, as Prashant mentioned, as we get into the hoarding question, it's not just the hoarding question, it's the optimization of supply around the stuff that's not just the vaccine, all the other stuff that's needed to make it work. But then there's also the thing in talking about the rights of the patients is we need to make sure that we're getting the messaging out there and that we're targeting not only the right communication, but the right groups and the right regions in the sequence that the process is going to work. And we need to be doing that in a way that understands the concerns of those target populations and that drives content at them that is attractive and engaging and is as attractive as and engaging as the stuff that may be circulating that discourages people. And then finally, I think, while being cognizant of the financing issues, the limitations in supply and processes by which countries will need to seek, the limited funding that will be available means countries are going to have to seek alternative supply sources, and especially through 2021. And it's important that in order to ensure equity, we're building the visibility mechanisms, and we're planning the supply and the resupply and the ongoing allocations and the ongoing funding issues as countries absorb a volume and as countries then need to procure more. So yeah, I think there's lots of different aspects to that. I think in terms of where we see it from a CHAI perspective, that rights-based principle is the fundamental of what we do. We absolutely believe that no individual should be prejudiced in their access to quality care by consequence of their geography or the status of their birth. And I think it's incumbent on all of us to be thinking really, really hard about how we make sure that carries through in the application of rollout.
Thank you, Ian. You mentioned something that I've spent a lot of time thinking about and working on, which is ensuring that the communications effort isn't also thought of as ancillary, right? If syringes and vials shouldn't be thought of as ancillary, the communication effort also shouldn't be thought of as ancillary, but should be kind of embedded in the vaccination campaigns, kind of, from before the beginning. And, Nina, I know this is something that you've also thought a lot about, worked a lot on. And I know kind of we share a concern for the absence of this happening, really anywhere in the world, including here in the United States and also here in New York City. Could you just talk a little bit about kind of what you think would be a good approach and would be a rights-based approach on kind of building public demand and trust kind of in the populations that are especially vulnerable, and kind of how you think of transparency as being a core part of that?
There's so much. It's super interesting panel. I think one of the things that surprised me from the beginning of the approach to COVID, one of the things, it's great for people who work in global health to sit in the middle of a pandemic and realize what sort of jerks they've been expounding to other people about how to do things, and then sit in your own pandemic. And one of the things that struck me very much in the New York approach was, I don't think I've ever been contacted once by my governor or mayor to ask me how I'm doing, what I think, what I need. I haven't had any question. My city councilor, nobody has come and asked me a question. And I think, I'd love to hear Precious talk about this a bit more, and Ian as well, because that's like 101 in health communications. Like, you actually talk to people, you ask them what their fears and concerns are. We're going to roll out, I'm working on a project now with some colleagues, I hope some of them are on it at Elmhurst, for the rollout of the vaccine. Nobody's really started to talk to the nursing staff yet, and we're going to pre-position vaccines in a couple of weeks. So everything we know from global health is community engagement means sitting down and talking to people. And okay, I get it, in the beginning, Zoom was weird, but we have community groups here and nobody is being engaged. So the communication, I was reading the governor's, and I'm not trying to be super critical, but you read the governor's plan and you read the state plan here, and they're all like, we're going to develop communication plans and we're going to deliver them to people. It's like that, people, that's just not the way it works in messaging. So I'm kind of shocked about that. I'd also like to say, if you don't mind, one thing about what Ian, well, I'd love to come back as well to this idea of what there's so many ways to get people engaged in vaccine campaigns. There's so many good practices. I was on a panel yesterday where we're talking about, giving people the day off work. But you need to know what people need in order to develop a policy that responds to those needs. So Governor Cuomo, if you're listening, call me up. I'll arrange a community group to speak to you about what we might be thinking.
Yeah, no, Nina, share your the dose of humility of living through a pandemic with multiple leadership failures at the local, state, and federal level, which I think tragically New York City has been a case study in. Precious, since Nina mentioned you, would you also just like to kind of share your thoughts kind of globally and also specifically in countries where you've worked in Africa, what you think needs to happen to really build public awareness, public demand, and public trust in both, I guess, the vaccines and then to participate in the vaccination campaigns?
Yeah. First off, it's about engaging with the community and listening and having a discussion. So I think typically the idea of a campaign is blasting messages one way. That's not communication. Communication is actually talking to the leaders, community people, and really understanding what are the community's priorities. You mentioned earlier that in some communities, they may have seen someone die of malaria, but they may not have come across anyone who's had COVID. How do you sort of balance demand in those sort of communities? And we've sort of, the general approach has been to push down the line as if once the vaccines land on the tarmac, somehow everything else will happen. It should be happening now. And what we've seen are that the countries that actually have done the best in terms of containing COVID anyway are the ones where the communications have been so good that community spirit is there. So that's understanding why maybe having a vaccine, you're also safeguarding a community member's life, for example. So I think there are different ways we should be doing that, but we should be doing it now. I think we're already late, but we can also leverage on technology. We know that people are getting misinformation on their various digital platforms. We should really be using those platforms to engage and have two-way conversations. It's true, removing offensive materials, misleading materials is important. But I think that two-way conversation is a piece that we haven't explored enough of, and we should be doing more of, because at the moment the sort of anti-vax communication seems to be in some places sort of just that bit step ahead. Even as fundamental as really explaining what is vaccination. What are the why do we think these particular vaccines are safe, and what is the cost benefit analysis of being at risk of getting COVID versus what happens when you take a vaccination. So all those conversations, I think, it's important that they happen. In order for them to happen, the budget has to be there. So it also does fall under something that should be included in the cost. Even though it's not directly related, I think using this opportunity to strengthen health systems overall will also improve buy-in, because it shouldn't be about, oh, let's just focus on COVID. It should be how, we mentioned earlier, I think it was Prashant who mentioned earlier, enabling regional manufacturing. Now, a regional manufacturing plant would also then be creating jobs, so people would know, actually, this is a good thing to have. So there are all these sort of what may not appear to be initially connected points, but it's all about building a picture where communities understand the benefit and can actually see a tangible outcome on health overall, and not just a very siloed approach to public health.
Yeah, thank you, Precious. And Prashant, since Precious kind of referenced you, would appreciate hearing your thoughts on this, especially kind of how you think about transparency of manufacturing, also transparency of safety concerns if they do emerge. I mean, we saw today kind of the data out of the UK that, two of the NHS workers who were given the first dose of the Pfizer vaccine had a strong allergic reaction, and kind of the need to be candid and transparent about that, while also still, as Precious said, being equally candid, transparent, and forceful about why vaccinations are so important. So how do you think about that from your perspective, and how do you think kind of the manufacturing dimension plays in here?
Yeah, so firstly, I think we need greater transparency, similar to what we're talking about, transparency and a wider channel of communication with the community. We need that from the global agencies that are operating in setting up manufacturing capacity or the contracts, whether it is COVAX, WHO Act Accelerator, with the country governments. There are National Immunization Task Force who've been asking, when will I know about the status of what we are getting when we are getting? And it's okay to tell them we don't know yet, but at least tell them something, right? Not engaging them, not having a wide communication channel creates a dynamic where they think, oh, this seems to be a black hole. We don't know what we're going to get here. Let's negotiate something bilaterally. And that hurts everybody. We don't want that dynamic to play out. So one is the role of communication, not only to the potential vaccinees and the community, but also to national government agencies from supranational agencies. The second is we have a lot of digital tools which can help us in larger community outreach. And digital tools doesn't necessarily mean just the tools which are directly reaching mobile phones, but digital tools which enable community volunteers to act quicker, faster, more efficiently. And many of the panelists here, including Shai, have worked on many such tools. So I think we just have to repurpose them quickly and use them in a wider scale for COVID-19 vaccine communication strategy. The challenge with communications is that it's much easier for the global monies to be used for buying something. It's much harder to say, off the 12 billion that the World Bank has, or the money that the COVAX has, we are going to use $1 billion of that and give it to countries to run communications plans. Because communications plans are run by agencies which are by design fragmented, smaller, in-country actors, whereas purchasing occurs from large global actors, so it's much easier. We feel our fiduciary risks are lower, therefore we sort of use that. So I think that's another area where we need to think about. The third is related to systems investments in things such as capturing adverse events following immunization in a much more distributed, larger way than we have historically in the past, right? So our systems for capturing adverse events for under 5 vaccination, childhood vaccinations are reasonably well developed, but we need to expand them for adult vaccination. That's an area we can invest in. It is a no regrets move because it's not just about COVID-19. If we develop them, even if some low income countries, which people are saying are not experiencing such a high COVID load, will create something which is useful for the future. So I think those are areas we need to remind people of and highlight in the global investment planning and prioritization.
Prashant, I completely and emphatically agree. And I just want to remind everyone who's joining us to please submit your questions, because we will soon turn to servicing your questions to our panelists. But Ian, I just want to really segue from what Prashant said about how historically, communications efforts have been fragmented for all the reasons that he outlined. Do you think that this is an area where CHAI could help play a role of trying to kind of consolidate and have more coherent efforts even within countries, although certainly also possibly across countries? And if not CHAI, like, who do you think could help really play this role? Because I do think, while of course we want messaging that is targeted to vulnerable communities, that is kind of specific and resonant and responsive, as Nina and Precious have both spoken about, to kind of communities' concerns as they themselves are articulating, we also do want there to be consistency of messaging. So while, I think tailoring is hugely important, it's also really important that we not have kind of messaging that's contra to itself, kind of from neighborhood to neighborhood or city to city or country to country. So just how do you think about this? Could CHAI play a role? And if not CHAI, like, who could try to help solve this kind of for COVID? And as Prashant has said, then hopefully kind of moving forward too.
It's a brilliant topic, Chelsea, and certainly one that I have been talking a lot to our people about, is saying, how do we provide the guidance around communication in health access? Because there's a learning here that's not only applicable to COVID and to COVID vaccine rollout, there's a learning here that could be applicable to anything, any conditionality. How do we educate and how do we communicate around screening for cervical cancer? How do we educate around management of childhood pneumonia? So there's all sorts of ways in which we can enhance the way in which health literacy is created within communities. And I definitely think that's something that CHAI can be assisting our partner governments to think about. We've been doing lots of work with Gavi and with COVAX, helping think through and helping provide advice around the cold chain requirements of high volume distribution and campaign style rollout to adults. We've also had lots of discussions around whether ultra cold chain is something that we should be investing in or encouraging investment in, because it's not going to be something that is of high usability in future, right? And there was a question that someone asked earlier on the chat about the campaign learnings that we've had from pharmaceutical companies, and could those be utilized? And I absolutely think that's a vital part, is that, the mention was made of the river blindness work of Merck, but there's also the Zithromax campaign work, there's the Diaflu campaign work. There's lots of different ways in which we can learn from the pharma experiences around these campaigns. But then we can also then take that forward in how do we then use that information for hepatitis elimination and for malaria elimination and for childhood vaccine coverage. But one last thing on communication that I think is really important. We have to ensure that the right people are driving the narrative, because everything we're hearing at the moment, whereas 6 months ago, every conversation was about ventilators, everything we're hearing at the moment is about vaccine and vaccine rollout. But as we're waiting for vaccines to arrive, we've got the entire crisis of requirements for oxygen availability and access to oxygen. And so there's lots of other issues that we need to be considering, we need to be working on in order to keep people keep the recovery rates high until we get to where the vaccine penetration is achievable. So I really think that the control or the drive or the definition of that communication is something that we need to spend lots of time on.
Please, Precious.
I just wanted to jump in. Ian mentioned the oxygen issue. This is a classic example of how an intervention that is being turbocharged by COVID is actually one that's been needed for a long time in terms of dealing with childhood pneumonia. So imagine, this is an opportunity to actually strengthen the oxygen chain, save children's lives, and also save lives of people with COVID. So I just want to jump in there as an example.
Yeah, thank you, Precious. And Nina, I think you also had some thoughts you wanted to share off of.
Yeah, there's two things I want to share. I mean, one is about this idea of communications. And I think what I learned at PopFam was that really means actually sitting down next to somebody and talking to them. And it's an individual, it's a one-by-one activity. So I still feel like we're totally missing the plot. And the name of Precious's organization, that's that idea of the tree, and we all sit around the tree, and that's where we talk and share. And I don't see that happening. And the other is this idea of campaigns. I guess this is the first discussion where I've heard that word. I don't think COVID should be delivered through a campaign approach. I think that's already setting up what we had, HIV exceptionalism. We need to figure out any vaccine to be successfully rolled out to 90 or 60 or 70% of the population has to be delivered through routine immunization. So back to the opportunities. I mean, unfortunately, I was the acting chief of health at UNICEF, and we did a gazillion campaigns, and they never contribute to strengthening health systems. And I think the groups that are working on LF or ONCO, they're also, it's a realization. We did a study that with London School, again, maybe Prashant can comment on this as well, but there's really no examples of campaigns that strengthen other health services. Even on measles, we tried to deliver vitamin A with measles, like super easy, doesn't happen. So we're not very good at that. So I'm with Ian on the optimism that, this is an opportunity, but strengthening what we call RI, routine immunization, and really getting out of this sort of militaristic campaign approach to vaccines, which has backfired time and again. I'd just like to share one other experience. The reason why I came to PopFam was because I worked in a refugee camp on the Thai-Lao border, and we had a measles outbreak, and there was a forced vaccine campaign, and the population was held and vaccinated. And that was fine for that one time, maybe, but it certainly didn't engender those people to a love of vaccination in future. So I'd really like to step back from this campaign idea and see if we can really talk about routine immunization and how we get this in through routine. Thanks for listening.
Yeah, no, thank you, Nina. And Prashant, do you have anything you'd like to add since Nina kind of referenced you, please?
No, I think I want to go back to this idea of how do we organize the market for health communications using the tools that Nina had led the market shaping or created the market shaping function in Gavi for how we buy in an organized manner. Chai does that for ARVs, many other products. So what I'm looking for is the tools of what we commonly call as market shaping. Can they be used more effectively for things other than just buying health technology, whether it's a vaccine or a medicine? And health communications would be a very fertile area, but I think there is need for continued dialogue and exploration as to how we can do it. Is our current repertoire of tools directly usable? Do we need to do something else around it? And we've got a lot of clever people who would be willing to contribute. Some who are experts in health communication, some who, like the panelists in this, know market shaping for the supply side. bringing them together. So that's my ask to at least both PopFam and to the Clinical Health Access Initiative.
Thank you, Prashant. There's I now want to get to the questions from our audience. The first question is, in many countries, though there may be a plan for distribution, there's a high risk of that the execution of such distribution will not be equitable. Are there technologies that can make the supply chain more equitable and transparent to at least ensure accountability? So maybe, this is really a question for everyone, but maybe, Prashant and Precious, kind of given your work in supply chains and technologies, you could start with answering this one.
I'll jump in. Yeah, I mean, there are platforms. I know the Africa CDC and the African Union have proposed several platforms where the tracking, for example, of the tests, whether someone's been tested, and that can, of course, be expanded to vaccination, can be done. And that can also, so using blockchain, so even when someone crosses the borders, that they actually have had a particular test in a specific country. So that technology is there. It does require countries, again, to work together, I think, because there will be some there's always cross-border movement. And so there has to be some sort of harmonization where data from one country can be shared with another. And that's where the rules and sort of regional agreements come into play in terms of sharing of health data.
Great, thank you, Precious. Prashant, any thoughts on this question?
I mean, yeah, there are technologies which can help us improve equity and perhaps even increase accountability. We've tried them in the medicines area. Chai works with many of them. I think the key here is that given that people are expecting a very compressed rollout, will it give us enough time to think about the technologies that are usable in a meaningful way, or in the rush to use the technology, would we end up using something which then we will go back and say, we should have thought about this and designed it with a slightly longer term view, or the shelf life for a health system should have been longer. So some things, yes, we absolutely have such technology which have been tried and tested. We have enough confidence, but some things are relatively new. And I wouldn't recommend using COVID-19 vaccine rollout as an opportunity to try out such new technologies in a very compressed selection sort of time frame.
I think all of that makes good sense to me, certainly. And I'm going to try to now be rapid, so then our final minutes we can get to as many questions as possible. There's a broad question, I think, really for all of you, of kind of what is the role of civil society and civil society organizations in the rollout of a COVID vaccine at any stage, or kind of on any front. Maybe Nina, you could kind of offer some thoughts here, and then we can kind of have others chime in.
Well, they're certainly not an afterthought, and they should be involved in every part of the process. I mean, in many places in the world, as you all know, they're the groups that actually deliver frontline healthcare to the most vulnerable. And, I just worry about all the communicating and telling and not enough of the listening. And I think CSOs are a great way to listen, at least as a proxy, or to get to the community as a tool for listening. I mean, there's one other trend as well that I see as not so positive, more on the international NGO side, the INGOs as we call them. There's a couple of big contracts that have been awarded for INGOs to go work with countries to develop plans. And that is like a global fund repeat happening all over again. In the early years of the global fund, we had rafts of consultants paid for by this, that, and the other government who went in and wrote a plan and gave it to the country, and wasn't that terrific? And then there was no ownership, no engagement. So civil society, I think it's really, I would hope that when in immunization, there are these things, there's There's for HIV, there's something called a country coordination mechanism. It's a very important point of global funds rollout. They have to meet and talk. Gavi has sort of an equivalent called the ICCM, which means all the immunization people are supposed to meet and talk and agree a plan. And I think that civil society is just generally excluded. Even if they're there, they're pretty much token and not called on. So I think we're going to have to, as a global community, do better on making sure that as part of the conditionality of this work, just like countries have to report gender disaggregated data on their vaccinations. It's not a question. They're not reporting it on COVID now to the WHO. There's very little gender disaggregated data on COVID deaths. It's like not a choice around COVID vaccines. And similarly, as we think about every stage of planning, just civil society just has to be part of it. And we have to do our best. I was thinking also, like we should have a male thing, like we're not supposed to speak on all male panels. We really shouldn't participate in meetings where there's not grassroots civil society there.
Totally agree. Any Precious?
Yeah, I just wanted to add that it's not only the right thing, it's the smart thing. It's the most cost-effective thing, because if we don't do this, we won't actually get people accepting a vaccine or really improve public health. The only way is the community has to be the core, because surely the work we're doing is to benefit communities. So how can we, as global health experts, be speaking on a different planet and engaging with the very communities we're saying we're there to serve? So it should be absolutely central. And I would say all these different mechanisms, COVAX, all of them should have a significant community component. And we should be able to see what that contribution has been. And it's not just about them being able to speak out. We want to actually have evidence that they've been heard and that actually this has actually changed how sort of the rollout, et cetera, has occurred.
Yep, Prashant, please.
Yeah, I want to stress one point of this, which is I think we know a lot from the HIV supply chain for antiretrovirals, how critical is the role of civil society. Every time there is a stock out, that information reaches the central agencies very, very quickly, because there are multiple grassroots level civil society actors who are tracking that. But I think we need to also be cognizant that the role of civil society has to be constructive. And for it to be constructive, they have to work very closely with technical experts. Oftentimes, people who work in academia or other technical functions, they are not as willing to lend their expertise so that someone in civil society truly understands that if there is a stock out, what could be the factors? It's not always corruption. It could be something genuinely technical that went wrong, right? So it is incumbent on us that as civil society actors track the COVID-19 vaccine, its equity, its global rollout, its rights-based approach, those of us who work in technical areas, work very collaboratively with them and create the right structures for that to happen.
Thank you all. Again, kind of now just racing to try to have all of your thoughts on a few more questions if possible. There's a question on how feasible is having a rights-based approach in countries where there's deep civil unrest, possibly even kind of large-scale violence occurring, large numbers of internally displaced people. How is a rights-based approach possible? Is it even possible in those types of settings? I don't know who would like to comment first.
I think one of the important things that I'm curious about is, around SAGE, when the HPV vaccine was approved, there was a really robust discussion that if you're...
Well, explain what SAGE, just explain what SAGE is.
Yeah, so it's a group of people, it's an expert committee at WHO that makes global recommendations on what vaccines should be picked up when by whom, and it looks at costs and it looks at effectiveness. So it gives a technical recommendation, but also sort of practical recommendations. And one of the things was about if you're in Jordan and you have Syrian refugees and you have that no man's zone, you still have to you don't have that much time to deliver things, and you have to prioritize what you deliver, and a lot of that is life-saving. So I think we also have to have a serious conversation about, is it is either the COVID vaccine an opportunity to get other life-saving things, or really maybe should we be doing measles vaccine if we have one shot at getting a life-saving tool in, looking at the epidemiology of the, of the crisis. I don't know, Terry, if that's a very unpopular or unrights-based approach, really.
Anyone else like to comment on this question or respond to Nina? If not, I'll just move on to the next question. And we received a few questions kind of centered on what are the responsibilities of pharmaceutical companies that we've kind of talked about, global, multilateral institutions, governments, kind of what do the panelists think about the responsibilities of pharma companies? Do they have an obligation to donate vaccines, to share their technologies? Kind of Terry mentioned kind of the push on TRIPS kind of about 6 weeks ago to try to kind of use that mechanism to kind of better democratize and effectively unpatent kind of the intellectual property of the vaccines. So just kind of what in our last few minutes, since kind of this question came up repeatedly from people who are watching, kind of what are your respective thoughts on pharma's responsibility on the intellectual property side, kind of on the distribution side, on kind of investing in building kind of regional manufacturing capacity and more broadly? And maybe we can just go around the screen. Maybe Nina, you're next to me on the screen, so maybe we can go, Nina, Prashant, kind of Precious, and then Ian.
I think that Prashant's point about decentralizing or how we think about manufacturing is going to be really important on this one. And there's been a great amount of focus on IP, which is important, but in vaccine production, know-how is also super important. And I tell people, who've never been to a vaccine plant, it's like going to a mixture between an ICU, intensive care unit in a hospital, and like a beer factory, because it's got like these huge vats and all that stuff has to be kept perfectly pure. And it's really easy to mess up. So this is not like manufacturing of like, antibiotics that you basically do in the back of your car. This is a very complex process. And I think we just have to keep in mind all those complexities. And I do think the Holy Grail is going to be figuring out how to really localize manufacturing. That's just my personal opinion.
Prashant?
Yeah, so I think about it as a three-step approach. The first is, of the companies who are a vaccine sponsor and or have a product that's already authorized or approved and are willing to work with additional manufacturers but have not found the right platforms. That is not about IP. That is largely about the global community finding a platform for them to do tech transfer. Tech transfer in this particular context is very resource intensive, which means the company or the recipient organization will have to invest resources in tech transfer. So first is create where there is already willingness. Why not at least take that willingness and work on creating a scale-out tech transfer approach? We know the willingness from at least one of the three leading companies, which is a relatively new company, wants to do it. The second is there are technologies. So firstly, like Lina said, in this case of vaccine manufacturing, the process is the product. Right? What you make is what is the process of making it. So, but we have a platform called messenger RNA, which will be a very versatile platform, not just for making COVID-19 vaccines, but for anything else that comes as a future pathogen. And having its production capacity only centralized in 3 locations or 4 locations in Europe and North America isn't the way that the rest of the world will accept. So we have to get ready to think about, yes, the infrastructure constraints are large. Yes, the know-how constraints are large, but we cannot shy away from saying that messenger RNA manufacturing will not occur in developing country in the future. It may not happen in the next 12 months, but we have to get ready for it. That's the second part, and the role of pharma and the bodies that represent pharma companies here is to show the willingness, and if they don't, we have to bring them to dialogue through whatever tools we have. The third thing in this is about the willingness of pharma companies who have a leading candidate to share resources amongst themselves. It's not just about transferring out, it's just about oh, you can use my factory because I think your vaccine has far higher efficacy than mine, or you can use the vials that I have on contract for next 500 million because my candidate isn't progressing well. So this idea of horizontal collaboration is something we've got to stress, and it is a role which is strictly embedded in the social contract that every pharma company has with society.
Precious.
Yeah, I was just going to add on some of the thinking is around the possibility of mixing and matching sort of different vaccines to get the best out of it. That clearly will require the pharma companies to actually to buy into that. So that's an example of collaboration across companies, and it's a really great opportunity for pharma companies to engage fully with the process of enabling equitable distribution of the vaccine. We know there were painful lessons that happened during the during HIV, the early stages of HIV, where it was horrific. I mean, Terry mentioned it. I experienced it, saw it firsthand, where depending on which side of the hemisphere you were at, you would live or die. So the pharma companies have the opportunity, and we have examples of candidates where there's a willingness to provide the know-how for countries. Yes, it's true that we can't just have a pop-up vaccine manufacturing plant at the drop of the hat. But there are certain countries, for example, South Africa, that can be with the right sort of outscaling and tech transfer that could quickly be able to start producing a vaccine. I also want to make the point that let's not forget that we're making the assumption that it's going to be after you've had your 2 doses, this is it. We don't know. This is a new a virus. It could be an annual thing. So in terms of economics, it doesn't even make sense to have a centralized manufacturing if every year we need a slightly different version of the vaccine. We still don't know.
Such an important point, Precious. And Ian, do you have any final reflections on that?
I think the willingness and the speed of response and engagement has been quite superb to observe. I think the way in which the industry has responded to this challenge has been quite superb. I think we do need to acknowledge that. The question I would ask off the back of it is, this new style of process, this new style of engagement, this new style of regulatory processing that has enabled us to get from problem to probable solution in incredibly short time. How do we make sure that becomes part of this thing we all call the new normal? How do we make sure that the benefits and the advantages that patients have been able to derive out of this changed way of thinking and acting is not just for this experience, but actually affects the way in which we manage health in future?
Well, yes, hopefully, and in this holiday season, at least in our family where we celebrate both Hanukkah and Christmas, kind of may that be the wish and the blessing for us moving forward. Just thank you all so much. This has been so tremendously helpful to me, and I'm sure to everyone watching and listening. And I just now want to hand it back to Terry to kind of close it out today.
Okay, I mostly just want to thank you, Chelsea, and thank you, panelists, for this really incredible conversation. I think we certainly in PopFam have a lot to work on for sure, but I have found this discussion to be very inspiring and very hopeful. So thank you all, and hope to see you all soon. Thanks, Chelsea.
Thank you, everyone. Stay safe.